So the way you do this, if the hip is extending, where is the roll of the femoral head? Yeah, so we gotta take a look at your kinesiology slides because there's a naming issue going on here, and this happens when we look at joints that are upside down. Right? So essentially what is happening, you have the acetabulum here, and you have the hip extending. So with convex concave, if you have a convex on a concave, the spin has to happen in the same direction as the swing. Right? Everyone agree with that? The swing is the limb movement.
Oh, the actual movement.
Okay? Everyone okay with that? So if that's the case, if we all agree with that, and we all agree that the head of the femur is convex on a concave acetabulum, as we extend the hip, the femur is swinging posteriorly. Everyone's good with that, right? So the roll has to be in the same direction as the swing. So the ball is trying to roll away this way. So we have to do the glide in the opposite direction, which is anterior. I know. That's what. So am I. That's why I want to see the slides from kinesiology.
Oh yeah. Is this for the spin?
Yeah, because
I want to see the slide. So this is a naming issue. So we can come back to discussing what the naming issue is, but the mobilization for extension is an anterior glide.
Yes.
Okay? So we'll just take that for now, and then we'll clean up the naming issue. Man, this is a heavy leg. So what we're going to do is we're going to get on the back of the hip joint, and we're going to glide it anteriorly. Okay? Because we just did hip flexion, and we did a glide for the hip posteriorly. So now we're going to do an anterior glide for hip extension. Yeah? Just.
do you have to be really careful because there's sometimes an anterior segmental,
Absolutely.
like
Yeah.
just like the shoulder.
Yeah, absolutely. 100%. So you wouldn't do this with someone who has an anterior laxity. You wouldn't do this with someone who has a labral tear.
So what if you had like I know the shoulder example was adhesive capsulitis, so you wouldn't want to do an anterior.
So I'm not going to go there yet because the clinical prediction guideline has this whole thing about which direction you will mobilize someone with adhesive capsulitis. And there's a large discussion that we're going to have as far as when there's a positional fault, you're correcting the positional fault. And that's a majority of the time what is going on. Okay? But from just a clean biomechanical standpoint, in order to gain hip extension, when you have a tight capsule, you're going to do an anterior glide. Okay? It is not often, rare, and maybe not ever, that you are actually going to glide the hip anteriorly to stretch the capsule. What I will say is, this is a fantastic technique to gain full hip extension. So if someone doesn't have full hip extension, someone has a crunchy hip, an osteoarthritic hip, gaining full hip extension with internal rotation is the closed pack position for the hip. That's what you want to give them. You definitely want to work on hip flexion because they also have trouble with sitting. But if you want to try and help early, if someone has early hip OA, and you want to help them to delay the progression, you want to give them full hip extension and internal rotation. Okay, and this is different than Cyriax's capsular pattern. This is more of a Kaltenborn perspective. But this technique works very well for this population. Okay? But your point is very well taken that anyone with anterior hip laxity, so all of you flexible bodies, really don't glide this person anteriorly. Okay? Okay? Yes? Yes, okay. You heard me? Yes? Yes? Okay. So, extend the hip, come right up to the point. You are going to have to get on the bottom of the crease of the butt, so I'm going to put my hand on the back of your hip. Is that okay? You're going to come in here and you're going to hug about where the posterior part of the ball and socket is. So you're going to need to get above the ischial tuberosity and you are below the greater trochanter. You're kind of hugging in about where the piriformis would be, and then you're going to do your anterior glide right here. Okay? I like to use the web space as you're seeing right here. You could palm it. You can get the palm in there, and you're getting an indirect mobilization. You're going through the musculature, but you can still get a pretty good anterior glide. Okay? You have something? You look like you had something to say.
Always, but
Always.
well, let's keep going.
Okay. The figure 4 technique what we're gonna do here is we're gonna bring the leg out and we're gonna start to rotate into external rotation. So now we're set up so the hip now is positioned going into the anterior part of the capsule. So here, this one is a good palm technique. You come in and the table will pretty much stabilize the innominate, but sometimes you might counter stabilize the innominate. With this innominate, I feel I want to counter stabilize. If you don't need to, or you could put towels in there, then you can back up your hand and do an anterior mob this way. You can go same side straight over. I will say for this technique, coming across this way, hugging in, doing anterior and kind of anterior lateral is a great technique. You come in here and you're going to mobilize, still the posterior part of the hip, you're going anterior and lateral and do your grade 2 oscillation. It's a great way to loosen up the hip. People who have crunchy hips and they lose that external rotation range of motion, you use this technique and you keep it at grade 1s and 2s to try and quiet down the anterior portion of glute min and glute med and the TFL, and they gain their hip external rotation range of motion. Okay? All right, so anterior glide and figure 4, 2 techniques. Thank you.